Next is Dr. Deep, Deepti Elizabeth Kurian.
Good morning, everybody. This is a study on orbital immunoglobulin G4 related disease, a disease of IgG4 positive plasma cells and fibrosis. So IgG4 related disease has systemic implications with no standard treatment protocol for orbital disease, and the factors affecting the outcome for orbital IgG4 disease are unclear. So although non-specific orbital inflammatory diseases usually present with signs of inflammation as seen on the right, IgG4 related disease of the orbit can vary from subtle proptosis to lacrimal gland involvement to aggressive orbital masses as seen on the left. So the aim of our study was to determine the proportion of IgG4 related disease among all non-specific fibroinflammatory diseases of the orbit and compare its clinical pathological characteristics, treatment outcome, and also compare the serum IgG4 level. It was a retrospective study over the past 8 years, and patients with prior treatment with immunomodulators, including steroids, were excluded. So we included 54 patients. And diagnosis of IgG4 was based on immunostaining, which showed more than 10 IgG4 positive plasma cells per high-power field and an IgG4 to IgG ratio of more than 40%. The most common primary treatment modality was pulse dose IV methylpred 3 weekly, with early concurrent immunomodulation with azathioprine starting with the fourth pulse. Complete response was declared in cases with complete radiological response or asymptomatic residual soft tissue after treatment for about 90 days, and recurrence if there was any activity within 90 days of stopping treatment and inactivity. So looking at the baseline features, they were similar in the IgG4 group and the non-IgG4 group, including bilaterality and even the serum IgG4 levels. There was significantly higher in the IgG4 group with a mean of 7.5 grams per liter. There was no difference in the signs and symptoms between the two groups either, and the tissue involvement radiologically was similar in both the groups, including lacrimal gland involvement, muscle thickening, and apical involvement. So both can present with lacrimal gland masses, muscle thickening, and intracorneal soft tissue. So pathological features, on the other hand, were starkly different between the two groups. And interestingly, although cases with storiform fibrosis were higher in the IgG4 group, overall the predominant form of fibrosis was lamellar and not storiform in the IgG4 group, as opposed to systemic diseases. And there was more of severe lymphoplasmacytic infiltration in the IgG4 group compared to the non-IgG4 group. Phlebitis, tissue, eosinophilia, perivascular fibrosis, and lymphoid follicles were significantly more in the IgG4 group. And of note again is that majority of phlebitis was non-obliterative as opposed to obliterative described in systemic diseases. Complete remission with primary treatment was seen only in 16% of IgG4 group compared to 34% in the non-IgG4 group. And an additional 25% responded to secondary treatment with other disease-modifying agents. Although not statistically significant, the overall complete remission was seen in 41.9% in the IgG4 group versus 56% in the non-IgG4 group. And there was a trend for more recurrence and an earlier recurrence in the IgG4 group compared to the other group. Shorter duration of symptoms and absence of proptosis was significantly showed us a better outcome in the IgG4 group, and bilaterality also was found to be favorable in the IgG4 group. Much to our dismay, none of the pathological features predicted outcome, and serum IgG4 did not correlate with treatment outcome either. But paradoxically, the mean serum levels and the proportion with higher serum levels were more in the orbital disease compared to what is described in systemic diseases. That was 7.5 grams per liter compared to 1.1 in systemic diseases. So in conclusion, IgG4 related disease may be more resistant to treatment and have earlier recurrence. Shorter duration and bilaterality were favorable, and orbital diseases has characteristic pathological features compared to systemic disease, and serum IgG4 was higher in orbital disease. So it might behave in a very characteristic way compared to systemic orbital IgG4 disease. Thank you.
Tablet azathioprine in all cases, like IG4 related or non-IG4 related orbital inflammatory disease in
Yes,
your
so
study?
that was the modality of treatment, but we didn't start
Because
azathioprine in all.
IG4 related orbital disease, they are very recalcitrant. They don't respond. So you need
Correct.
a better immunomodulatory agents to tackle this type of
Right.
IG4 related orbital
Yeah.
disease.
So if there's a drastic or a dramatic response with the pulse dose steroids itself, we don't always start them on immunomodulation, but that was the case in most of the cases. Azathioprine we prefer that because it can be monitored easily by an ophthalmologist. It has a better pharmacodynamics. That's why we start azathioprine ourselves than referring to a rheumatologist. Otherwise,
Ideally, in all these type of cases, must
will take time.
consult
Correct.
rheumatologist
Yeah.
because
So
nowadays better
yeah.
immunomodulatory agents are available. So
Okay.
it's better to switch over to the newer immunomodulator.
Got it.
The mean follow-up period was not mentioned.
It was not different in both the groups. In the IgG4 group, it was about 4 years, and in the non-IgG4 group, it was over 3 years. But there was no statistical
That's important
difference.
because the mean duration for development of systemic lymphoma following a diagnosis of IgG4 is 5.5 years. That
Got
could
it.
probably be the most significant outcome of your group, where you could say that not just asynchronous but also concurrent systemic lymphoma is also noted
Got it.
higher in the IgG4 group. So
Okay.
if you can follow the same group
Right.
out, in a couple of years you could come and tell us that
Got it.
whether the
Yeah.
incidence of systemic lymphoma was higher or not. Also, your recurrence was 2 versus 4, and in a pool of 84 patients, 2 versus 4 is not really something I'd make a statement and say recurrence was seen higher in one group.
Higher,
It's not
right,
significant
yeah.
at all.
Yeah. Yeah. We need to include more. We had a problem with numbers because we did exclude all the patients who were already treated
Yeah.
with steroids, so we were
You could
limited that
actually
way.
include them as well
and
to
see
longitudinal outcomes.
outcome. Got it.
Well presented. Okay.
Thank you.